these questions first. Okay, so welcome everybody to my Q&A. Thank you for joining me. I hope you guys are getting ready for the exam. I remember the first time I wrote it, I was so nervous right the week before the exam. So I want to say that it's normal to feel nervous. Um, you know, you'll be glad once it's over. To be honest, I'll be glad once it's over too. And yeah, I hope you guys have learned a lot. And with this session, it's just to be a very casual session. Feel free to ask. I'm going to answer the people who email me first, and then I'll open it up to whoever wants to go and wants to ask questions. I just want to make sure that the chat function is working. So if you don't mind, can you just type in the city where you're from, just as a small icebreaker, just to make sure that everything's working here. Perfect. Okay, lots of people from all over. Welcome, welcome, everybody. Okay, perfect. Okay, so I'm going to go answer Leslie's questions first because she was the first person who emailed me. So she was wondering when ACEs and ARBs would be added. So definitely if they have hypertension, you would add it. But if so, and the target for people with diabetes is 130/80. But the easiest way to determine kind of all these cardiovascular protection medications is this website here, Reducing Vascular Risk. This is on the Diabetes Canada website in the clinical practice tools under, where is it under? Here, tools and resources, and then under macrovascular complications. So here, tools and resources, and I have to admit some people, and then macrovascular complications, and then it's just under here, reducing vascular risk. So what we could do here is, okay, let's say we have a 55-year-old patient who does not have any kind of previous cardiovascular issues. Oops, sorry. I have to admit people, I have to watch the chat, so I just have a lot of multiple things I have to do here. Okay, so whoops. So let's say they don't have any previous CV cardiovascular issue. So because if they've had a previous heart attack, if they've had a previous stroke, they should be on ASA, statin, and ACEs and ARBs, regardless if their blood pressure is high, to keep their risk low. So, okay, but let's say they don't, and let's say they're exactly 55 years of age. And let's say they're completely newly diagnosed. They do not have any, they were just newly diagnosed. Okay, some more people coming in. Now, here's the important part. If they don't have any risk factors at all, you can see that an ACE and ARB is not recommended. So if they have no, if your cholesterol's fine, if they have no high blood pressure, if they have no albuminuria, smoking, then an ACE or ARB is not recommended. However, if you change this to yes, then this changes, and it is recommended. So it's for 55 and CV risk factor. So the way to memorize that is through here, this thing here, this algorithm here. And okay, more people coming in. Okay. And so what's important is that you start from the top, because if you start from the bottom, it's like, okay, they're not over 40, therefore they don't need anything. But no, if they've had a if they've had a cerebrovascular accident, cardiac attack, stroke, then even if they're under 40, they would be on a statin, an ACE, or an ARB, and an ASA. So you start from the top and go from the bottom. Some people try to go from the bottom and go up, and that's the wrong way to do it. That leads to a bunch of wrong answers on the question. So remember to start from the top and then go from the bottom. And this is the best way to memorize the cardiovascular protection medications. Okay, so Leslie, if you're online, could you just give me a thumbs up or just unmute and say yes if I've answered your question? Okay, I'm guessing that.
That's great. Thank you.
Okay, no problem. Okay, so when are GLPs preferred for MACE prevention over SGLT1? If GLP would be preferred if someone over 60, And yeah, so that's a tricky question. If you look at the guidelines, they actually have fairly equal evidence. So if you look here, you'll see that for MACE, liraglutide and dulaglutide, no, wait, sorry, yes, for MACE, here we go. Grade 1A evidence for liraglutide and dulaglutide. So that's Victoza and Trulicity, and then level grade B for semaglutide. The reason why semaglutide is grade B is that they just did a non-inferiority trial. So they said that, okay, we're similar to Victoza, whereas Victoza and Trulicity actually went out of their way and did a cardiovascular trial. So that's why it's grade B for Ozempic. And you can see here it's grade A for Jardiance and then grade B for canagliflozin, which is Invokana. So really for if you're trying to prevent more people coming in, if you're trying to prevent, then this is secondary prevention. You can really use either. If you look at the little diagram here, you can see that both have grade A evidence for some of their agents. So really you can use either or. Now for primary prevention, Trulicity has the most evidence. If you look, so those are people who've never had a heart attack or stroke. That is right. I have to admit some more people. Okay, that is right. Okay, I had it before I came in. This one, yeah. Trulicity is really the one that has shown the best for primary prevention. And so yeah, that's the 6 years with at least CV. So I have to admit these people in. Okay. So Trulicity has shown the best evidence for that. Yeah. And none of the SGLT2s have shown really that great of evidence for primary prevention. So yes, I would, if it's for primary prevention, I would always use a GLP-1. Okay. And okay, and Keisha's question kind of adds to that discussion. So she was wondering about additive effects of GLP-1s and SGLT2s. So right now the question is, okay, if a GLP say reduces their cardiovascular risk by 30%, and then an SGLT2 reduces their risk by 30%. If we put a person on both, do we get a 60% reduction in their CV risk reduction? And the answer is we don't know yet. It could be 60%. Maybe it doesn't actually work that well together and it's only 40%. Maybe you only get 30%, or maybe they somehow cancel each other out and it's 20%. So we don't know if 30 plus 30 equals 60 right now. There's ongoing research seeing if indeed that if you put an if you combine an SGLT2 and a GLP-1, if it actually comes out with a better outcome. But those studies are ongoing and they're not out yet. So they definitely won't be on the exam. But that's what I mean by additive cardiovascular effects. We don't know if putting a GLP-1 and an SGLT2 should combine to equal a 60% reduction. We kind of assume it does at this current moment, but there's no evidence to say, yes, for sure, this study says yes. Yeah. And okay, you're shaking your head, Keisha, so I assume that I've answered your question. Okay, perfect. So now I'll just open it up to the chat. Here, let me open up the chat. Yes, you can use it, but Trulicity is better for primary. You could see, you can look at the evidence, all the evidence, whoopsies. There. The evidence is down here. So grade A for dulaglutide, Trulicity, grade B for liraglutide, and grade C for semaglutide. So definitely not the greatest of evidence, but other ones. Okay, so I've got some questions in the chat, and I know you can't see the chat, which is a bit of a problem. Whoops. So know you can't see the chat, which is a bit of a problem. So I'll try to copy it into my webpage here. Give me 1 sec. And there's some more people coming in. Just 1 sec. You can't see it, but I have like 5 windows blinking at me for people to admit people, for the chat and everything. Okay. So we've got a question from Harry saying the MDD prevalence in diabetes, 10% or 40 to 60%? I believe it's like kind of like 30 to 40%. I could look it up. Let's see. Like, I don't know any of these statistics offhand. I'm not writing the test. So let's see if they mention anything about it in the updated guidelines. Here we go. Or if anyone has an answer, feel free to put it in too. Oh, okay, someone is. Perfect. Thank you, Lauren. I appreciate that. Saves me the trouble of looking it up. Okay. So let's see what else is in the chat. Yiren asks, when we are calculating insulin, do we always round down to prevent hypo? So that'd be yes. We would prefer a patient to be a little bit high than for them to go low. Okay. Akash asks, what's the advantages of Baqsimi? So Baqsimi is the nasal glucagon. And the advantage is that it's much easier to use and much easier to train people to use. So they've done studies that show that, like, even if you're trained to use the IM glucagon, half the people in emergency situation still do it incorrectly. So, but currently, like, if you wanted the IM glucagon, it comes in a little vial, and there's a little bit powder inside, and they have a diluent. So you have to use a needle, get the diluent, put it into the powder, mix it up, then take all the glucagon on, and then inject it into a person. Now, if you're not a medical professional and your husband is convulsing on the ground, foaming at the mouth with a hypo, you might not be so calm to be able to get the diluent, use the syringe to get the diluent out, put the diluent into the thing, shake for 15 seconds or whatever, take the stuff out with the needle, and then put it into your husband. So Baqsimi is just a nasal spray. You click it and then squeeze it into the person's nose. So I believe there's actually some drug manufacturers are actually discontinuing IM glucagon. So Baqsimi might be the only choice coming soon. But that's the advantage of Baqsimi. It's much easier to use, especially in an emergency situation, especially if you're not a healthcare professional who's proficient with needles. It's just easier to get it into the person and get quick treatment. Okay, so let's see what other questions we have here. Okay, I have a question on self-monitoring. Yeah, so Appendix 5 is out of date. There is oops, just people trying to get in, sorry. Let me just admit them. So Appendix 5 is out of date. Use the updated version. I have a cheat sheet on that right here. Let me show you guys. So yeah, like there was a new self-glucose monitoring chapter in 2021. So that supersedes all of the older chapters. So I have a cheat sheet right here. And if it's loading like this, that means the website is just busy. Just go open a new tab or reload document and it'll show up right away. And here is what to do. Yeah. Okay, so the name is 083084085. So I hope that answers your question. Okay. Oh, you can see the chat? That's great. Oh, but I think the chat isn't recorded. That's a problem. Okay, calculation from A1C. Yeah, so I have it in the thing. It's like A1C minus 6. Here, let me just see here. It's A1C minus 6 times 2 plus 6. Yeah. Here, let me just type it out. A1C. I have it in one of my cheat sheets, I believe, but I'll just write it out here. You can just double check in my cheat sheet to make sure I put it in correctly. Okay, there you go. Oh, perfect. Okay. Okay, now where am I? Yeah, you could do that too. 10%. Okay. Okay. Why not much? MPen asks, why guidelines does not talk much about Ozempic versus Ozempic is so popular, med doctors prescribe. So I don't understand that question, MPen. If you can unmute and explain it, that would be great. Why guidelines does not talk about Ozempic versus Ozempic is so popular. Yeah, sorry, I don't understand the question, MPen. So if you're here, if you could unmute.
So when I read the guidelines,
Yes.
I don't see they talk much about Ozempic versus they talk more about Trulicity and other GLP-RA. But when I see in real life, the doctors, they mostly prescribe Ozempic versus I don't see much prescription for Trulicity.
Okay, so the guidelines talk about semaglutide, and I don't in when I read it, I don't see any preference over one or the other. Which province do you live in? Maybe it's a coverage issue.
Alberta.
Okay, so in Alberta, and I'm from Alberta, so I know this, Ozempic is covered by Seniors Blue Cross and Trulicity is not.
Okay, that could be the reason.
Yeah, that is 100, no, that is 100% the reason. So
Okay. Okay, makes sense.
yeah, like when something's $25 every 3 months and the other thing is like, I don't know, $300 every 3 months, 400, seniors are obviously going to choose one or the other.
Okay,
Okay.
thank you.
No problem. And that brings up a good point. Like, this is a national exam, so you can't assume that, oh, it's covered in Alberta, therefore it's covered across Canada. So you can't assume it. Like, if there's a question that says, like, okay, this senior's poor and can't afford medications, well, oh, Ozempic's covered in Alberta, so it must be covered in every other province. So I'll put them on Ozempic. But that would be wrong because you can't assume that what's covered in your province is covered in every other province. Remember, it's a national exam. There's no Alberta version, there's no Ontario version. All of you are writing exactly the same exam. Okay, so let's see what other questions do we have here. Can you go through once self? So, okay, so this would be it for self-monitoring for blood glucose. I believe, yeah. So this, like, I know that the new guidelines aren't, I know the old guidelines were actually probably a little bit more clear, but unfortunately the exam is on the new guidelines, so that's what you got to study through. For types of learners, okay, so yes, so this has sometimes showed up so Lauren asked, for types of learners, I find it difficult to distinguish between accommodators and converters. Any hints? So this has sometimes shown up on the exam. If this does show up on exam, let me know in the post-exam forum. Don't say the exact question, but just say that this kind of question showed up. And unfortunately, I don't have any hints for that. I find that whole thing very confusing as well. There is more information on this in my after practice exam review. So right over, I'm not sure if it has shown up lately, so hopefully it just doesn't show up because it's so confusing. But yeah, there's these, no, I don't even have that. Here, I don't know if it showed up in the last website, so last exam, so that's why I didn't add anything. I will add something here for that. Here, let me make a note. Accommodation, convergers, yeah. I will add a link to a website that I used to link people to for that has more information on that kind of stuff, but I don't have any hints. I find it really confusing as well. Okay, so I'm just going down. Oops, someone's waiting in the waiting room. Yes, it has the same dose. Baqsimi only, so Keisha's asking glucagon IM is 1, but Baqsimi intranasally is 3. Both have the same effect, and it's yes. For Baqsimi, there's only one dosing. Can you briefly go about fasting and guidelines? I'm gonna have to ask you for a more specific question. I can't or you can email me or put in an exam form, but that's an entire chapter, and I can't just briefly go over an entire chapter. Like I do have a chapter study guide on it, so you can look at that. It is right. Are you talking about intermittent fasting, or are you talking about Ramadan fasting? It is right. Here. Yep. So, and then I've got some questions here. So you can review that about Ramadan fasting, which I'm assuming you're talking about. If you're talking about intermittent fasting, that's actually covered more in the low carb diet section. Neither like I know that Dr. Jason Fung is like the proponent for intermittent fasting in Canada, but I feel that he has some research, but there could be more. So low carb diets also talks a little bit about intermittent fasting, if that's what you're talking about. Thank you. Okay. Okay. Yiren asks, for DM screening in indigenous population, does the frequency of screening increase every 6 to 12 months because of high risk, or should we follow the flow chart? So you would follow the flow chart. Indigenous is one of many risk factors, so you would just follow the flow chart. Best choice of blood thinner. I'm not sure actually. I don't do a lot of like I used to do INR clinics and stuff like that, but I don't think that'll show up on the test, so I'm not sure which one's the best blood thinner. So yes, Sonia's asking, is meglitides now included in the SADMANS guidelines? So this has been something that I've gone back and forth about, but I would have to say yes, because there was a new, let me show you, SADMANS chart I have put it in the appendices. Where is that? It's this one, I think. Nope. No, here's the updated one. Okay. And it actually did include repaglinide right here, glucanorm, which is a meglitide. I was like, technically, they don't require that much renal function to work, but I guess if they are really, really dehydrated, it could cause lows. So yes, I've decided to add them to the SADMANS because this is the latest one. And so, yeah, so there it is. Sonia also asks, is metformin withheld before any surgery as SGLT are to be held prior to surgery? So that depends on what kind of surgery they're having. Depending on, so that really depends on what kind of surgery they're having. Different provinces actually seem to have different guidelines about how much to reduce insulin and reduce their medications and stuff like that. I doubt that there'll be a question on the exam on that because there is no universally accepted guideline. And yeah, this would highly depend on what kind of surgery you're having and a lot of other factors. Typically it'll be like a internal medicine consult before, or sometimes if they can't get one, then they'll ask me to change around their diabetes medications. And so for myself, I just used AHS guidelines.
Esmond, this is Sonia. Good
Oh, hi.
evening.
Oh, hi, Sonia. How are you doing
Hi,
today?
everybody. I'm good, Esmond. Thank you for conducting these sessions for us all. We are very
Oh, no
nervous,
problem.
but I feel very prepped up with your materials.
Oh, thank you.
Esmond, in the update in the guidelines and the pharmacological update, which is related to Chapter 13,
Hmm.
there is a slide that talks about SGLT2 to be held during major surgeries. But I wasn't sure if metformin also has to be withheld if a patient is going for a major surgery. So
Hmm.
I was clear about SGLT2 in the guideline. There is a slide on the update of 13 chapter, which is talking about pharmacological therapy
Hmm.
in the update, actually.
Okay.
Um, I think it's slide 41 or 42 because I just did that with my colleague. But I wasn't sure if you have any insights about metformin.
Um, Typically, so this is from, again, it kind of depends on the surgery. Typically, most diabetes medications, if they're in the morning, are held. So if you take a look at this, no, no, this is the wrong one. This is Ontario one, I believe. Anyway, so typically, what I've seen is that the surgeon will hold most of the medications, the morning medications before. So if you're on metformin, SGLT2, sulfonylurea, all of that will be held because the patient will be NPO during surgery.
Thank you. That's sufficient. Yes, and
Oh,
I
okay.
know that, yeah, that's a quite a logic that we would apply because the endocrinologist would withheld all these before anybody is going for a major operative surgery.
Hmm.
Makes sense. Yeah, I wasn't
Okay,
too sure about metformin, but now I am. Thank you, Esmond.
no problem. Okay, so Ramadan fasting. Harry, you've got some things here, but I can't really see. Oh, okay, perfect. Thank you. So Harry has some resources on that convergent learner, accommodative learner, stuff like that. So just take a look at that. Thank you. Education and research competency. How many questions are there on the exam? Yeah, so here we can find out. So if we go here, let me just close. So if you look at here, okay, so this comes from the CDE-CB website. It's Appendix A. You can take a look at it as well. So the weightings here are 1A is the most, 2A is the second most, 1B is the third most, and 2B is the least. So you can take a look at this and kind of get an idea of how many questions a topic will have on exam. So for example, something like pathophysiology has 1A, so there's going to be a lot of questions. Whereas the education stuff, it's like 2A, 2B, those have the least amount of questions. Let me show you something here. Okay, so you can see here that so 1A has 56 questions, 1B 42, 28, and 2B is 14. If you add that all up, there's 140 questions. However, the exam itself is 165 questions. So what are those extra 25 questions? Those are sample questions or pilot questions that they're testing to see if they make sense and will be used in the next exam. So, but now you won't know if a question is a pilot question or not. So if you come across this really funny looking question and you don't know how to answer it, don't spend a lot of time on it because it might be a pilot question. And so, because even if you get a pilot question right, it's worth 0 marks. So even if you spend like 3 hours or something like that to try to get this one pilot question right, you get exactly 0 marks for it. So if there's a question that you don't understand, that you don't know, just skip it, come back to it. On Top Hat, you don't have to answer every question sequentially. You can skip questions. It's no problem to do that. So you want to manage your time and make sure that you're using your time efficiently. pilot questions by nature tend to sound a little bit funny because they're testing to see if it is a valid question. So for every question, don't spend too much on it. And if a question is really weird, don't panic over it. It might be a pilot question that is worth 0 marks anyway. Yeah. Okay, so here, let's see here. Thank you, Keisha. That's good. Yes, and anything that could cause acute kidney injury, metformin should be held. Oh, I got
Esmond,
here. Yes.
this is Sonia again. Sorry to
Yes, no problem.
interrupt the entire group, but rather than texting, I
Mhm.
thought I'll ask you my question here. Maybe others can also benefit.
Sure.
So one of the essentials, which I do not have an access to, by the way, but I trust your materials and I know I will pass the exam by doing them.
Thank you.
We have a discussion group, and in one of my colleague said a question. I'm going to read it to the entire group.
Sure.
What should parents be taught to do when their child with type 1 diabetes has a cold, a blood glucose reading greater than 13 millimoles,
Mhm.
and refuses to eat solid foods? So
Okay.
that's probably the catch, refuses to eat solid foods. And the options as meant are A, withhold the insulin until the child is able to eat.
Mhm.
B, replace the meals with clear fluids containing carbohydrates.
Mhm.
C, encourage the child to eat small amount of foods more frequently. Last, take the child, which is option D, take your child to emergency department for intravenous fluid replacement. So we, of course, know it's not an emergency situation. So D is out. It's just throwing us.
Mhm.
C, I would repeat for my colleagues here, is encourage the child to eat small amounts of food more frequently, which, of course, this poor child is refusing to eat, so is out.
Mhm.
Now, I'm confused, Esmond, between A and B. So A says again, withhold the insulin until the child is able to eat. And B is replace the meals with clear fluids containing carbohydrates. So
Mhm.
I will tell you that I answered it B. So
Mhm.
I said B is the correct answer based on my knowledge and,
Mhm.
that we would not tell the child to omit insulin. But to
Mhm.
my surprise, the answer was A.
Really?
Yeah,
I would have 100% one with B as well. You never
right?
hold insulin. Are
Okay,
you
so
sure?
probably it's maybe a typo that we were like debating,
Yeah.
because I was thrown up completely and I was like, why would we withhold insulin? We are never doing
No,
that, right?
you never do that.
Okay, so thank you for confirming that here. Thank you.
No problem. And yeah, as you can see, everyone else thinks B as well. So I think you kind of have a high degree of confidence that was just a typo. For calculating BMI, it's just meters over kilograms squared. It's really easy to do with a calculator. Okay. Yeah, and then that's the end of the chat. If anybody wants to like put up their hand or ask, let's see here. Could you clarify insulin adjustment on slide 16 of, okay, sure. Help, okay, let's see. One sec. That was in my after practice exam review. Dr. Halprin's slide. And he's a great presenter. If you ever have a chance to, yeah, here you go. Slide 16, okay. This one right here, okay. So, okay, so when you're traveling west, you require more insulin because your day is getting longer. So they take 24, okay. Yeah, so they're gaining 13 hours. So basically they're gaining half a day. So what they're doing is that they're giving, so the normal dose is 24 units. And so now their day, instead of 24 hours, is 36 hours. So that's why they're giving another 12 units 12 hours later to kind of because it's like 50% more, because 24 hours, they're getting 12 hours is about 50% as much. So they take 24 and 50% of 24 is another 12 units. So that's what they're doing. They're waiting for the 12 hours, taking another 12 units, and then the second night they return to the regular schedule and take 24. Does that answer your question, Yuren? Yes, okay, perfect. Yeah. And it's good that it's nice that you guys, so I'm just looking at AEC, yeah, kilogram divided by M by M. Yes, it's the fastest way to do BMI. And it's nice that you did have calculators. I remember the first time I wrote, like we didn't have, it used to be in like, we had to drive to University of Calgary. In Calgary, sometimes it's still snowing in May. And for the University of Calgary, you have to pay like $20 to park like 15 minutes away. And you weren't allowed a calculator. And there was this question, it was like, the answer was like 2, 4, 5, and 6. And I got like, I was trying to do math on a piece of paper and I got like 0.2. So obviously I can't do long division anymore.
Hi, Espen. Can I ask one question?
Yeah, absolutely. What's up?
For Prazogel and other, it's always preferred over clopidogrel.
Okay.
Even but in practice, we always see that clopidogrel is the one which is widely prescribed. So, is there any reason for that one? There was also one question in context to that.
Okay. I don't see a lot of clopidogrel in my practice. I think it's because in Alberta, clopidogrel is covered, whereas Prazogel and other ones require special authorization. So in Alberta, that's the reason why, I believe. So yeah.
Okay, that answers that. Yeah.
Okay. Okay. Okay, so yeah, if anybody wants to put their hands up and ask questions, it's good. I think it's a good idea to split this into 3 because last time, like people were like asking me questions right up to the last minute. So I guess it's good that I split it up into 3 and then people can ask more leisurely. Yeah, but please feel free to put your hand up or just unmute and ask a question. I'm happy to. I want to make sure you're confident for the exam.
Hi, Esmond. Sorry
Yes.
to bother you.
Yeah, no, it's not a bother.
This slide that you have up here with the traveling west and east,
Mhm.
where did you go to get that? Sorry, I have that's the first time I've seen that.
No problem. So here, let me see. So you go to, so it's in my after practice exam review.
Okay. I haven't gone to the after practice, so
yeah, then it's right here under traveling of Dr. Halperin. You click on it, and then you have to click on this to download it.
okay, thank you.
Yeah. Okay. So I've got some other questions in the chat. Are my practice examinations sufficient to cover it? Yes. That's why I have a pretty good exam pass rate. Okay, essentials binder. Now, the problem, Michelle, is that is based on old guidelines. I have the essentials binders too. Which version do you have? Because I do have actually all the answers to the latest one that is a binder, but the newest ones are all online.
So I have hold on. I think I have the 5th edition, which is the one that you have, like,
Is it?
because
Okay.
you upload the question guides, or like the answer key.
Yeah. Okay.
But you have the same version.
Okay, perfect. Okay. I think this is one of, give me one sec. I think this is a question that confused me as well, 97, the adolescent one. So okay, where did I even put it? Okay, so if you have the latest binder version of the essentials, I do actually have the answers here. So 97 was C. Let me just see what I said. I think I disagreed with the people. Yeah, see, I respectfully disagree. So the worst patient, like the most poorly controlled patients I have are not like really old type 2 people. They're actually really young type 1 people. For example, I have a 25-year-old female with type 1 diabetes who needs a heart transplant because her A1C has been like 15 for like 3 years. So just very poorly controlled, wanted islet transplant, got it, but didn't follow up, didn't take any of the anti-rejection medications. Just really, there's some mental health issues too. But my most poorly controlled patients are actually young people with type 1. And so when this question said that, oh, it's okay not to have like a transition or something like that, I 100% disagree with that. C is supposedly correct. Except, see, this is an except question.
Mhm.
So I think it's complete. I would 100% disagree with this answer. I think
Okay.
C is probably
Yeah.
the most important
That's
thing,
what I'm thinking as well. Okay.
given my previous experience with people with young people with type 1 diabetes. So yeah, maybe it's a typo. Maybe yeah, I'm not sure, but I totally disagree with this answer.
Mhm.
Yeah.
Thanks.
No problem. Okay. Oh, okay. Harry, okay, we've got another. Is this one of mine for 98? This one?
Yeah.
Oh, okay. So, okay, let's see. Harry's been walking around his park for 2 months. He states he's feeling so much better and his blood glucose are in 8 range. The best response is. See, this is another one where I respectfully disagree.
Okay, sure. Yeah.
So I don't know why they chose that. I didn't write this question, so
Mhm.
I don't know.
Okay, that's good. Yeah, I disagree with that as well. So that's why I just want to clarify. Okay, sounds good. Thanks.
Okay, this next funniest question about east and west of Toronto, Ontario. So usually they'll say person needs to travel west or needs to travel east because that's right. Like I guess, yeah, like I don't know, like Morocco. Is Morocco east of Calgary or is Morocco west of Calgary? But usually they'll say east or west, I believe, in the latest ones. But that is a good question, Sonia. Like you don't want to be like caught out with that. So that's good thinking.
Thank
Not-
you.
Not a stupid question at all. Not a stupid question at all. Okay. Of all the times I've written the CD exams, I always have 1 to 2 questions about. Okay, yeah. So thank you, Harry, for putting that chart. I'll put another chart into. I'll put a web page. I hope it's still active. I'll put a web page into the practice exam review that talks about those styles more. It didn't show. I don't think it showed up in my exam the last time I wrote, so that's why I stopped putting questions into my exam. But maybe they have come back. Yeah, perfect. Another one. Thank you, Emily.
Hi, it's Celia again. I just have a question.
Sure.
So I do really well with the medicines. I'm a pharmacist by training and the dietitian, but those learning questions or teaching questions I really struggle with. If
Mhm.
you fail one section of the exam, is that a not pass? Like you have to pass all the different categories?
Mhm. So, so I have a little like I've seen people's fail letters when they've sent it to me when they're asking for a refund. So usually you have to do like really like below 40% in a area. Like there was one person who did like I don't know like 80 60 80 60 and then got 40 in one section and then they did fail because of that. So you like I think if you're like 90 90 90 and like 60 that would be a pass, but if you're like 90 90 90 30 or 40 then yes you probably would fail that.
Okay.
Yeah, as long as you don't completely bomb it. Like I've seen people with like yeah like usually most that's just happened to one person, but well, a couple people. But usually the fail letters that I get, like the person clearly failed. They did like 40 in PAFO and nutrition or something like that. Yes, I have seen like 80, 80, 60, and then 40 in education theory, and then they did fail. But in general, the people who don't pass do bad in multiple sections.
Okay. Thank you.
Okay. Perfect. Thank you for that. Okay. Yeah. So that's the end of the chat questions. Anyone else have any questions, concerns?
You can hear me?
Oh yeah. Hi, Nikolai. How are you?
Hi, good. I have pediatric questions. If kid diagnosed with type 1, we start with MDI or we start with basal and bolus? Do you know? You wrote you're not good at pediatric questions, but what the policy?
Okay. So
Maybe you know?
basal bolus and MDI is the same thing, multiple daily injections.
No,
And
I mean, for example, one one basal and one bolus with lunch or dinner, or we do like MDI from very beginning after diagnosis
Mhm.
for pediatric patients.
I would assume they do MDI,
Okay.
even for pediatric patients, because yeah, like people like go on insulin pumps when they're kids. So I definitely think that it'd be MDI. I can't say for certain because I don't work in pediatrics, but I would definitely say MDI.
Okay, if we discuss with teenager and we suspect some drugs consuming, we can ask directly, are you consuming drug or what's the what we should do?
So that requires some clinical judgment. I haven't worked in pediatrics, but for adults, I'd bring up kind of like, it's been a stressful time. COVID has been hard for everyone. How much have you been drinking lately? There's been a lot of alcohol, like a lot of people have been using alcohol to deal with the increased level of stress. So that's kind of how I would approach it for an adult. I assume that'd be kind of how you would approach it for a child, but I guess with the child, like the parents or the
And
guardians.
we're not allowed to inform parents, right?
I have no idea.
If we suspect.
I have absolutely no idea. I don't work in pediatrics. Yeah, so I have absolutely no idea. If someone else works in pediatrics, they feel free to hop on. But yeah, I have no idea about that.
Okay, no problem.
Yeah. Okay. So Cash says CCM model. So what exactly is the question about the CCM model? Like, where do you find it, or what? Like, if I say diabetes, as like, what exactly is your question? Like in terms of where to find it, it is in a lot of people are on my website. This is normally doesn't take this long.
Hi, Esmond.
Yes.
I also have a similar question with the chronic, like the CCM. I just tend
Okay.
to get confused with like, the process indicator. I think it's more the process indicator. Like I think outcome I can get that it's about like looking at like, results of A1C and like, they're able to demo back, and structure is like a structure indicator is like, adequate privacy and like, the whole system. But then process indicator, if you can maybe briefly like discuss like what's an example of it.
Sure. Here, let's go. So for that, there's actually also in my after practices. Let me just close some of these windows. Okay. So right here. Oh, that is having trouble loading. Okay. So let's see here. Okay. So structure, process, and outcome standards. So if you're looking at this, there are and I know this is confusing, and I'm not a specialist in this myself. Okay. So structure is kind of like how you would structure a diabetes program. So it'd be like, okay, we're going to this is the staffing. Are we like a 24-hour center? If we're not a 24-hour center, who do we refer to? Like we need emergency. Like if we are an emergent, if we do handle diabetes 24 hours, then we need like access to like IV and DKA and specialists and stuff like that. Who do we refer to? Who do we get guidelines from? Those are kind of like structure standards. And then for process standards, those are like, okay, how do we when the patient is in, what is our way of educating them? What's our process of it? Do we do follow-up appointments? How often? Stuff like that. Do we handle, if we're going to teach, do we use this handout and stuff like that? And an outcome is like, okay, are we getting people to A1C, their to target? Are we getting their ACR to target? Things like that. Yeah. Okay, and then Akash has some other questions. So those are the indicators. The CCM model is right here. So, for example, with these roles, like decision support would be something like the Diabetes Canada guidelines. For the community, they'll be like, okay, this person struggles with mental health or struggles with food insecurity. So do we have a food bank available? Do we have psychology or like a place where we can refer people for mental health issues, that kind of things. For self-management, it'd be like helping them develop their own personal skills. Yeah. Decision support system would be like the guidelines. They help us decide what medications to go and when to screen and stuff like that. Delivery system design is kind of like which EMR are you going to use? Are you going to do teleconference, or is it strictly just inpatient appointments, that kind of stuff? For 083, 084, 085, the slide about insulin adjustment is in my after practice exam review under Dr. Halperin. Okay. Okay, so there's 7 minutes left. Any other questions or concerns, or maybe we'll just end a little bit early?
Can you sort of show where to find the two handouts that you're so where to find this current one, and then where to find that the CCM one, the after exam one?
Okay, so this is in chapter, this is an organization of diabetes care. So this is, and that's right here. And that other one is right here, and it's at the end of the after practice exam review. Oops, okay, where is it? Okay, it's the standard of diabetes education. Sometimes it's not showing up because a lot of people are on the website, but you can just download it and it'll show up right away. Yeah,
Thank you.
So all of the answers to your questions are right here. There's lots and lots of examples here. Okay, perfect. Well, yeah, no problem. I do want to give, I should have maybe did this at the beginning, but I do want to give a couple of tips. So there's three traits that I think you should avoid on the exam. One is changing your answer. Typically, people who fail change their answer a lot. You should go 99% of the time, you should just go with whatever answer you put first. Usually that seems to be correct. It's your gut instinct, and then people kind of think themselves into the wrong answer. So if you're in doubt, just go with your first answer. Two is to just watch your time. That's why I've got a timer on my practice exams. You don't have to be too fast or too slow. Like some people will try to rush through the exam. There's no need for that. That's why I put those trick questions in there to force you to slow down. Usually most people have a lot of time. If you feel yourself getting nervous or something like that, then just do those 7 deep breaths as I mentioned, and just slow down. And most of the time you have more than enough time. The other trait that people have, that for people who don't pass the exam, it's this thing called fantasy thinking. So they'll see a question and it says this patient has type 1 diabetes. And then for some reason in their mind, they think, oh, because he has type 1 diabetes, they must be 20 years old. And oh, because they're young, they must live in Toronto. And oh, because they live in Toronto, they must vote Liberal. And oh, because they vote Liberal, they must be a vegetarian. And oh, because they're a vegetarian, they must have a sensitive stomach. Oh, so then metformin and GLP-1 are the wrong answers. But the answer just says they have type 1 diabetes. You can't assume that they're young. If it says they have diabetes, they could be 100 or they could be 1. So you can't say, oh, this guy has diabetes. The guidelines say everyone over 40 must be on a statin, therefore they should be on a statin. Like it just says they have diabetes. You can't assume that they're over 40. They could be 1, they could be 100. So just slow down when you're reading that question. And if you don't do those leaps of logic, I don't know why. Like I don't do that, so it's hard for me to understand why people who fail keep doing that. But just read the question slowly, don't leap to any conclusions, and just go slowly. If you've gotten a good mark, like 80% on my exams, if you got 80% on my exam, you probably have a really good chance of passing already. So I have taken tomorrow and Friday off. I will be on the exam forum. I will probably answer your question in a couple of hours. If you have any questions at all, please feel free to put them on the exam forum. And yeah, I hope you the best of luck. Thank you. All right. You guys have a wonderful night. Thank you for all your questions. Okay, how do I end this again? Oh yeah, here we go.